All right, can you guys see my slides? All right, perfect. So I want to start, and this echoes some of what Nora had just finished saying, that in terms of what happens next, families and patients are personal experts on this question already, and we can learn a lot from everyone that's here today about this topic. What we'll discuss is, what do we know, what does this mean, and what do we want to know related to the next phases. First of all, to highlight what do we know, Nora had mentioned this some yesterday as well, but the amount of research and literature related to FIRES and NORSE has increased dramatically in the recent years. So over here is 2021, looking back over here is 1989, and this is when you do a PubMed search. And so here you can see that in the recent years, there's 185 papers with NORSE, mentioning the term NORSE, 135 for FIRES, and just how much of that has been in the last several years. So we are learning more, but as you'll see, there's still a lot that we do not know. When we talk about long-term outcomes, we're thinking of things like epilepsy, cognitive impairment, and then another area that I termed kind of plus, other things to think about with what goes along with NORSE and FIRES. This is a picture from Dr. Specchio that outlines a little bit when we kind of broadly, in terms of conceptualizing NORSE and FIRES and the different stages that we talk about. And so this takes in a little bit about some of the presenting features over here on the left that you can see that we went through yesterday. And then here's the acute phase that we also talked about some yesterday. And then what we'll be focusing on here is, you know, what happens next? What is this, what's termed chronic phase in NORSE and FIRES, and what do we see with that? You can see here they list some of the different things that I've already mentioned, as well as behavioral disturbances. And then for some individuals, you know, like we've mentioned, there's loss as well. So talking about the epilepsy component and what we know. So we know that after NORSE or FIRES, greater than 85 to 90% of patients will have chronic epilepsy, and those who survive. This epilepsy tends to typically start immediately after the acute phase. And some other conditions, there can be a break during that time, and you might not have epilepsy until years later, such as after a traumatic brain injury. But one of the key features about NORSE and FIRES is that that epilepsy tends to start kind of as a continuum after that initial presentation. In the chronic phase, there's often focal or multifocal seizures, meaning they can come from one area or from different areas, sometimes with a pattern of clustering. Often there's ongoing seizures despite medical therapy. And so the seizures at that point are termed drug resistant if they aren't responding to medications. There are case reports of a relapsing course, but often it's thought about more as there's only one acute period. But I think there's probably some individuals in the audience who have experienced a slightly different pattern than that. And again, there is case reports of that in the literature. Seizure treatment in the chronic phase is an area that we don't know as much about, and there's not as much literature. So we know that there's an average of 2 to 4 anti-seizure medications after discharge. Medications to use in the chronic phase, there's really not any trials to help decide that and what would be most effective for these specific conditions of NORSE and FIRES, only case reports. There's case reports of cannabidiol attempted in the chronic phase in 5 patients. With some benefit reported for some of those patients. Vagus nerve stimulation has been reported in 2 patients and has had a decrease in seizures. Again, most of these aren't resulting in complete seizure freedom, but could have a reduction in seizures. There's a report of responsive nerve stimulation. So this is a type of device that's implanted with electrodes inside the head, and that can stimulate. Dr. Payne talked about this briefly yesterday. That's been reported in 1 patient and tried. Anakinra, which you guys heard a lot about yesterday, there's a report of that used in a chronic relapsing phase of FIRES in 1 patient. And then even deep brain stimulation, which is a newer treatment for drug-resistant epilepsy, has been attempted in 2 patients. And so again, these are all small numbers, small case series. It makes it really hard to be able to make any larger statements about the treatment in the chronic phase and what medications or treatments are going to be most helpful. In terms of the cognitive outcomes, so this is a description from a paper by Kramer in 2011 regarding outcome data of 77 children who presented with FIRES. And I think one of the challenges that we have with the cognitive outcomes is that things are kind of put into very broad categories, and we'll go into this in a little bit more detail, but we often don't have as much detail about those outcomes as we wish we could. And so in this paper, they found that about 16% of patients were normal. There's then a range of borderline cognitive levels and mild intellectual disability that makes up this all together over a third of patients, almost half of patients. And then you have moderate, severe intellectual disability and what's termed vegetative state on this other end. And then still, as we discussed yesterday, about 12% of patients will die and pass away from NORSE or FIRES. One of the challenges with the cognitive outcomes, and as we're having discussions with families about this topic, is a lot of the literature that is available related to NORSE and FIRES is looking more at the acute phase, and then the cognitive outcomes are kind of like you've seen in that graph that I showed you right before, where it's normal, mildly abnormal, moderately severe. And I think as a parent or a family member, as a patient, that always might not have as much meaning in terms of what that means in day-to-day life. And so I think that's another challenge that we face with NORSE and FIRES, and how to conceptualize what is happening. And so here's just some tables of some other papers and the outcomes and how they described it. And so again, it's kind of very broad terms in terms of a normal intelligence quotient, learning disability, vegetative state or severe mental retardation or intellectual disability. And then this paper, from a cognitive standpoint, they tried to look at, and again, small number, only 7 patients, if patients were walking, if they were talking, if they had any abnormal movements. So again, numbers are small, and the categories of how we're grouping these things are pretty broad. There is one paper looking at neuropsychology testing in patients with FIRES. This is from 2006 and was before the term FIRES was used. So it's reported on devastating epileptic encephalopathy in school-age children, which is a term that was used prior to the term FIRES becoming more readily used. And so in this study, they found, it was 14 patients, I believe, that few patients have a normal IQ. There's language disorders with impairment in word finding and fluency. There's often memory deficits, attention concerns in many patients, and emotional and behavioral disorders. And this is just an example here on the side of what's a memory task, and the ability to replicate that drawing that they were supposed to do. A next piece is about rehabilitation and recovery. And this is something that there's really not much data available in the literature for NORSE and FIRES. I think we have to consider reference to other types of brain injury when we're considering the recovery from NORSE and FIRES, because again, there's not a lot of literature there, and that the rehab team, therapists, neuropsychologists are all an essential part of this team. There is, when we're thinking about recovery from a traumatic brain injury, there is more literature to guide what those rehabilitation recovery models should look like. And so I think in the state where we don't have specific data about NORSE and FIRES, I think we need to consider turning to other types of literature that's available to help guide us on what that looks like. So these are just 2 papers here that one talks about cognitive rehabilitation, and another one, a chapter that pretty broadly goes over rehabilitation after traumatic brain injury. And so I think we just need to also consider what we can learn from other conditions due to the shortage of literature about NORSE and FIRES and the long-term outcomes. The information and conditions that I consider kind of in the plus or additional considerations that we may not get as much attention in all the papers or literature, but are things like long-term nutrition. So some individuals after NORSE or FIRES are able to feed and eat on their own again. Other individuals, other patients need help with nutrition with things like a G-tube that goes into their stomach, and so a gastrostomy tube. And so those are other things that aren't always picked up in the articles and literature, but that I think is an important component when we're talking about long-term outcomes. Breathing support is another thing. So in the acute phase, often patients are needing help with their breathing, either with a tube that's going through their throat or straight or through their mouth into their throat. And then sometimes in the long-term phase, we can see that as well. And so it's another thing that we don't have all the data to help guide us, but that is important to consider. Anecdotally, I've seen patients who have had gastrointestinal symptoms as something that they're dealing with in the later acute and chronic phase related to NORSE and FIRES. And so again, we don't have much data to guide us about what that looks like, but there's other organ systems that we can sometimes see that may be after having a prolonged hospitalization in an intensive care unit, but that are really important when we're talking about what life looks like next and what this means for families and patients. There can also be physical motor limitations as well. And so again, that's something where we work with our rehabilitation team and our therapists to help with. And then again, after being in intensive care unit and very sick for a long time, there can be other health concerns that come up. And so these are all things that we need to consider as we're thinking down the road and helping families and patients prepare for next steps. So what does this mean? I think this is something that I imagine as a family and a parent, as a patient, is really important. You know, we can talk about the normal, mildly abnormal, moderately, you know, from a cognitive standpoint, but I think that's sometimes hard to conceptualize and what that means for day-to-day life and what things will look like. And so these are just some kind of questions that come to mind about what does this mean for daily life for patients and families. So will my loved one wake up again? Will they be the same person when they wake up again? Will they be able to breathe on their own? Will they laugh and smile? Will they be able to talk and walk again? What will life look like and what care will they need? Will they return to work or school? Will we be able to travel? Will my child be able to live on their own when they are older? What medications and treatments will they need? And will I be able to work still? And how will we financially adjust to this? I think these are all questions that probably come up as we're considering long-term and next steps. I think these questions are really hard to answer. These types of questions, we don't always have all the information to be able to answer, and we are poor with detailed prognostication, especially in rare conditions. And so I think that is just some of the challenges with this. We can try to use the framework of best case, worst case, and most likely when talking with families, which I think can help to families to be able to conceptualize and process this a little bit. I empower families if they're having these discussions to encourage their providers to, and their physicians and clinicians to try and phrase things in best case, worst case, most likely scenarios to help with this. There's challenges overall in communicating prognosis and talking about long-term outcomes. This is due to the range of possible outcomes, provider uncertainty, fear of causing distress, both from a provider standpoint, feeling unprepared, and then also the family's readiness. And this is just a summary of kind of some of the takeaway points, like I just mentioned, to help with some of those challenges. So best case, worst case, most likely. Talking about things early in the course is a key point that came out yesterday in our communication breakout sessions. And so I think talking about prognosis was something and long-term outcomes that was mentioned during that time as well, and then involving the team in these discussions too. Lastly, in the last few minutes, we'll just go over what we do. What do we want to know and what we hope to know? I encourage all of you guys to enter in the chat any things about what do you want to know, what would help from a long-term outcome standpoint, and just to help with this ongoing conversation about this topic. Things that I wonder about is, does earlier control of seizures improve long-term outcomes? We think that it will, we hope that it does, but I don't think that we in NORSE and FIRES have focused as much on the long-term outcomes just yet. Will early treatment with targeted therapy improve long-term outcomes? And so thinking about some of the newer attempted treatments like anakinra and tocilizumab, you know, we've seen improvements in the acute phase. There's less detailed information about long-term and what that looks like after these treatments. What medications are helpful in treating seizures in the chronic phase? How can we better support families and patients in the transition to home? And what is the best rehabilitation model to maximize recovery? These are all questions that I hope that we'll have answers to in the future, but I also encourage you all to add your own questions to the chat as well. Overall, I hope that through collaborative research with patients, families, and physicians will allow us to better understand the long-term outcome for NORSE and FIRES. Again, like I mentioned at the start, families and patients here today are already experts on this topic, and we have a lot to learn from each of you. The NORSE Family Registry that Nora has already mentioned this morning and that you'll hear more about is also an important step for us to be able to answer some of these long-term outcome questions as well. All right, I'm going to stop sharing my screen for a second. All right. So thank you for letting me go through the initial talk on long-term outcomes. We have a few additional talks to follow on the same topic. I'm going to introduce them both right now. So the first person is going to be Dr. Teneille Gofton. And for anyone who wasn't here yesterday, she is an associate professor at Western University in Canada and a member of the NORSE Institute Medical Advisory Board. She's a neurocritical care and palliative care physician with a research interest in NORSE and status epilepticus. She's the principal investigator for the NORSE Family Registry that you guys will hear more about as well. After her, I'll just introduce, it's okay, you're fine. I'll just introduce Dr. Erica Sieg real quick. She is a neuropsychologist at Northwestern University and works with patients with epilepsy, and I know has an interest in better understanding to the outcomes related to NORSE and FIRES as well. So we're really excited that she's able to speak with us all today too. All right.
Okay, so I'm going to chat a little bit about decision-making and the role of the palliative care team. So palliative care, right off, I think they're two very scary words, and they're often misunderstood because the role is not well understood within our greater communities. So I'm going to review some of that here. Recently, palliative care was redefined in order to try and get at some myths for it being appropriate only for end of life. And so the most recent consensus-based definition for palliative care is that it's an active and holistic care that is intended for people with serious illness, serious health-related suffering due to a serious illness. So note that the part that's not included in this definition is that it's not only for people at end of life, but it can be for people with serious illness who are not necessarily at end of life. The goal is to improve the quality of care of patients and to improve the quality of care for their families, their caregivers, and the supports that we have. It also includes these elements among many others, but I think these are the important ones for today's discussion. It includes a focus on facilitating effective communication, which was a topic of discussion yesterday. It's applicable throughout the course of an illness, and it's usually provided in conjunction with, not exclusive of, disease-modifying or curative treatments. The goal is to affirm life and not to focus on dying, and the goal is to provide support during the illness and, if necessary, during the bereavement periods. The other important aspect is that it tries to focus a lot on cultural values and beliefs in the context of the individual that you're caring for. So how is palliative care applicable to NORSE and FIRES? Everybody, I think, here knows this well, but if we think about the timeline of NORSE and FIRES, somebody develops symptoms and they develop status epilepticus. And after that, during these two periods is when you go for help. And then there's usually a very rapid admission to the intensive care unit. This is followed by or happens in tandem with a consult to neurology. There's a period of aggressive treatment, and then there's these periods of uncertainty that we've talked about, and often a prolonged admission to ICU. And so the question is, what next after that? And this is something that you don't need any reminder of, but a person who is affected by NORSE or FIRES, no matter what age they are, is often in a very complex environment with a lot of pieces of information to piece together, which is bewildering and overwhelming for any family at the best of times. So when you have NORSE or FIRES, as I said, it's usually a prolonged ICU admission that may last days or weeks, and there's often difficult decision-making with not accurate information about prognosis, which makes that very difficult. And these conditions will often cause the medical team to struggle because it's unclear when to introduce discussions about having palliative care involved. Should this be from day one? Should this be in 2 weeks? Should this be partway through when something specific happens? It's also very difficult for medical teams to know and understand when it is most reasonable to consider transitioning from a purely curative goal with therapies to palliative discussions in cases where a cure may not be possible. When medical interventions no longer change neurologic outcomes is normally when that will happen, but it's unclear in NORSE and FIRES when you specifically won't have any more good effect from medical interventions. So when seizures can't be controlled despite multiple anti-seizure medications and general anesthesia, as you know, it affects healthy young individuals, and there's often not a specific cause, which makes discussions, again, very, very difficult. And as Dr. Eschbach just outlined, there are many physical changes and intellectual changes that can be expected in the future. So despite medicine's best efforts, in NORSE and FIRES, mortality is a real risk, and long-term functional disability is also a real risk. And the unknowns make discussions difficult. So if the palliative care team can't change the outcome, what are the ways they can help? And the goals of the palliative care team really are to be expert communicators and to provide support, not only to the patient from a symptom point of view, if that's pertinent, but also to the family and the circle of care of not professional caregivers. The healthcare team also needs support in times like this, and this is behind the scenes that the family doesn't necessarily see, but the palliative care team can be a support for the healthcare team as well as the family. Expert symptom management when needed. If somebody's emerging from the anesthesia and it has discomfort for particular reasons, then the palliative care team can focus on that. They're also expert at helping to navigate grief, which can happen before the time of death, as I'm sure that everybody present today has experienced or seen, is that grief can be anticipatory, and this needs support before the admission to hospital is over. And they're also expert at end-of-life care when that is needed. So Nora was paramount in putting together a publication that we have done looking specifically at how we can incorporate palliative care into NORSE. And some of the important elements that the palliative care team can help with are making sure that we have an appropriate shared decision-making process. They're able to bring many of the different medical teams to the table and talk about things in a unified manner. They're also helpful in communicating prognosis and in supporting the substitute decision maker in very difficult times. As I said before, they can support the healthcare team, who can have a lot of difficulties transitioning from solely curative aimed treatment to more palliative oriented treatments also. And then the goal is also to communicate and to manage any symptoms that individuals are having, and if necessary, to help with transitions to comfort-oriented care. And then to extend to families contacts for bereavement support in their communities where possible. So the palliative team does this by making sure that the right medical team members are present for family meetings at the right times. Their aim is also to make sure the right family members are present for meetings, so to make sure that we can accommodate having everybody in the room so everybody hears the same words. They're also expert at reframing treatment plans in a way to make them consistent with the patients and families' values. And so the goal is really, we can do a lot of things with medicine, but it's to make sure that the treatments we're providing are in line with what the patient and family are hoping for in that situation. We also focus on promoting hope while planning for all possible outcomes, just like those that Dr. Eschbach described. So the palliative care teams in other settings have been shown to reduce medical interventions that aren't going to change eventual outcomes. Specifically, this is thought to be because of the in-depth discussions that take place when they're involved, and also the fact that it's focused more on patient values. They also have been shown to help make sure that the treatment plan is aligned with the patient and the family's goals. So overall, the take-home points are that the palliative care team is applicable at any stage of illness. And so as soon as this becomes a difficult and complex admission to hospital, no matter what the outcome, it's appropriate to have the palliative care team involved. And I think this comment came up a couple of times yesterday with our breakout sessions and with some of the stories that were shared. The palliative care team really focuses on communication and brings together the different players in the medical team. And that helps, I think, provide some clarity and concrete information for families. The palliative care teams also provide an additional layer of support outside of what the ICU normally is able to provide. And they're a good link to community supports also, which might be something that the ICU struggles with a little bit more. Early involvement of the palliative team can be beneficial. It may improve shared decision-making, and it also aims to enhance the patient and family-centered care. So while those two words of palliative care are quite daunting, They are a very helpful addition to any medical team in a complex illness. And I think the earlier they're involved, the better, because they can help bridge these communication and difficult conversations that are taking place the whole time that somebody's in hospital. So I think we can transition to our next speaker.
Thank you, Teneille. Let's see, Dr. Sieg, if you're ready, you can share your screen and start.
Yep. Okay, does everyone have a reasonable view? Okay, good. So I'm Dr. Erica Sieg. I am a neuropsychologist at Northwestern Memorial Hospital. I often work with patients who have autoimmune encephalitis and oftentimes have NORSE. I work with patients who have epilepsy in the roles of neuropsychological assessment, which I'll talk about, as well as psychotherapy. I have a psychotherapy clinic for patients who have epilepsy, oftentimes from NORSE, and I work with patients and families who have been impacted by these conditions. I will say my specialty is adult, so I'm not speaking as much about children in my talk, but generally the same approaches do apply. So I'm not going to spend too much time reviewing the outcomes because the two prior speakers did an amazing job providing all that great background information. The thing that I will highlight is that there is, my next slide, that there's a wide range of outcome. And as it relates to future planning, because there can be such a range of outcomes, it can be very difficult for doctors to be able to say from the beginning what the future might look like, as well as what needs to be in place to support that future. Generally, as time goes on, additional details and more specific recommendations can be provided, but there are a number of factors that might influence that. Other important challenges that might be relevant to patients and families affected by NORSE and FIRES is that because it's a rare condition, as everyone has mentioned, dedicated services are not common, which means that needing to utilize services for other conditions might be very important. I'll talk about those in a minute as well. The other factor is there are specific diagnoses that are necessary in order to receive services after hospitalization. So something like a major neurocognitive disorder or brain injury are necessary to qualify for certain services after the hospital. So a major neurocognitive disorder means that someone's cognitive or thinking someone has cognitive or thinking problems that interfere with their ability to complete their normal daily tasks, meaning they need help to do normal daily things like cook meals, manage medications, complete their own finances. Brain injury is a vast umbrella term that is typically considered and most common when you hear it be traumatic brain injury, which is that brain injury that occurs after an accident or some sort of external injury, force injury or acceleration injury. But brain injury can also occur from other medical causes such as NORSE and FIRES, where the brain tissue has been damaged and that causes a change in people's thinking abilities, and it also causes behavioral and emotional challenges. Now, because NORSE and FIRES are not as common, as I mentioned, patients and families often need to utilize well-established resources for more common neurological conditions to get post-hospitalization treatments, such as stroke, traumatic brain injury, or dementia. Now, dementia is a term that is synonymous with a major neurocognitive disorder. Major neurocognitive disorder is the newest, most updated fancy term, but essentially a dementia or a major neurocognitive disorder occurs when someone's no longer able to perform their normal daily activities. The term dementia, though, is generally associated with a condition that continues to decline with time, but a major neurocognitive disorder does not necessarily decline with time and may stay persistent at a certain rate. So the major neurocognitive disorder does give a little more accuracy and applicability, I think, to NORSE and FIRES patients versus dementia that might raise alarms of oh, this is neurodegenerative like Alzheimer's disease, and might keep getting worse with time. Although, as we've seen, outcomes are very unclear at this point and an area of need for future research. But this is the terminology, and it's important for patients and families to be aware that this terminology might be necessary for insurance purposes, for different facilities that might need a specific diagnosis such as this in order to qualify for services. The term NORSE or status epilepticus might not qualify people for the services that they need. So very important to be familiar with these sort of terms. And neuropsychologists or the epilepsy team can often provide the diagnosis for these conditions, or these labels, I should say. Now, as it relates to continued needs after the hospital, there's a wide range of services available, and I would encourage patients and families to try and use as many as possible just to have a broad support net. So there's first and foremost the epilepsy team in certain medical centers and for certain patients where the etiology or the reason for having NORSE or FIRES is an autoimmune encephalitis. Immunology may also be involved in addition to the epilepsy team. But in some hospitals, they're so closely linked that it all can be bundled in the epilepsy team. But in some cases, you might have an immunologist as a primary provider as well. There's significant need for rehabilitation oftentimes after NORSE and FIRES, and I'll go into more detail about each of these elements. There's legal needs, social work needs, family and caregiver needs, and then neuropsychology and neuropsychiatry that sound very similar, but I'll be sure to point out the distinct differences and unique areas that both of those can support patients and families who have been impacted by NORSE and FIRES. So to start out, the epilepsy team, as I said, they will coordinate anti-epileptic medications and coordinate care in the event of relapse. These are the pivotal providers in continuing treatment and care for patients who have had NORSE or FIRES going forward. Additional at-home tests that may need to occur are EEGs, electroencephalographies, that continue to make sure that no seizures are present once a person goes home. You can have those tests done at home. Epilepsy teams are good about providing red flags, basically the things in which patients and families should look out for that might indicate that their neurologic status is worsening or that they might be headed for a relapse. And the sooner you can recognize those signs, the sooner you can come back and seek care and get necessary interventions for those. Also being mindful of health and safety procedures to be used at home, oftentimes given the ongoing epilepsy that continues to occur, as well as medication management, safety precautions, things like dietary restrictions, driving and activity restrictions related to seizures are all very important pieces of information to get from the epilepsy team. Social work is pivotal and crucial. These individuals help coordinate and find services. They can address issues related to financial burden and can help order medication and physical equipment, help coordinate all those additional pieces, given there are so many that patients with NORSE and FIRES might need. And at a time when there's already so much tumultuous upheaval, these individuals can help keep a streamlined approach. Now, legal needs are also something that social work can assist with, and oftentimes are needed after there's a determination of what the outcomes might look like. So as a patient's getting ready to leave the hospital, you might have a better patients and families and providers might have a better idea about what long-term legal needs might be. That might be something called guardianship, where one person becomes the legal guardian of another because that person's unable to care for themselves or make sound decisions for themselves. And also legal disability is often necessary for a time or permanently in patients who have had NORSE or FIRES. Now, rehabilitation is a very crucial element for a lot of individuals who have had NORSE and FIRES. That's because of the significance of the medical condition itself. People's bodies become deconditioned. Oftentimes they've encountered something that changes their brain significantly. And so rehabilitation is usually a very important post-hospitalization step. Rehabilitation is often overseen by a physical medicine and rehabilitation doctor in the specialty of PM&R, often called a physiatrist. It includes physical therapists, occupational therapists, and speech and language therapists. And the goals are to improve cognitive and physical functioning where possible, so that a person can gain an understanding, person and their family can gain an understanding of safety needs and implement safety and activities of daily living, like going to the bathroom, showering, getting dressed, eating, cooking meals, anything related to how we go about our day. And most rehabilitation addresses basic functions like walking and talking and taking care of oneself. Usually a patient's evaluated for rehabilitation needs prior to leaving the hospital. Now, there are different types of rehabilitation. There's inpatient rehabilitation, which is where a patient actually lives at the rehabilitation facility or stays at the rehabilitation facility. So they'll go from the hospital to a rehabilitation facility where they will stay for overnight and oftentimes for several nights to learn the necessary skills. Generally, that happens for patients who have had sustained moderate to severe injuries, and they need more help to establish safety and mobility prior to returning home. So these are the patients, unfortunately, that if they go home would not be safe, or their families wouldn't be able to care for them if they went home. So it's oftentimes just as important for families to attend rehabilitation with their loved one to learn how to help their loved one once they go home. Now, outpatient rehabilitation is similar, except in this instance, a person is safe to go home immediately after the hospital, but might benefit from additional services to improve some of those functionings. Generally, that's for patients who have sustained a mild to moderate injury. Occasionally, where there's no physical needs or primary safety needs at home, a person might be eligible for just outpatient cognitive rehabilitation, which is where a person has total mobility and is able to live at home with the support of their loved ones, but might need compensation strategies for their thinking abilities, things like remembering, paying attention, solving problems. And that's the lowest level of kind of rehabilitation that one can have. Now, neuropsychology. So I'm a neuropsychologist, and we're psychologists who specialize in assessing brain function, usually in the setting of neurologic illness or disease. And the assessments are non-invasive. There's no physical side effects. They're paper and pencil tasks. People often refer to them as like standardized testing for school. They know we're getting at something, but can't quite figure out what. But we assess how people's brains can pay attention, how they can remember things, how well they can speak and use language, how well they can perceive their environment and navigate visual spatial information, and how well they can solve problems and think analytically and critically and make decisions. And this helps to understand the nature and extent of any residual brain dysfunction that might have happened as a result of having NORSE or FIRES. We continue to guide treatment planning and make recommendations, and oftentimes having a neuropsychological assessment can help inform cognitive prognostic aspects, as well as functional prognostic aspects. So the neuropsychologist generally does address important questions like, can this person return to school? Can they return to work? Can they live independently or raise their children independently? Can they drive, make complex medical decisions, or remain in charge of their finances? And we also evaluate behavioral and psychiatric needs as well that can occur after NORSE and FIRES. The timing of this, generally, it happens after a person has left the hospital. And that's because a person needs to be medically stable for neuropsychological testing results to be valid for any length of time. If you test someone just after they're coming out of their coma, they're obviously not going to be as functional as if you assess them after they've been able to complete rehabilitation therapies and be at a more long-term baseline that might actually be able to predict future needs as well as future outcomes. A neuropsychiatrist, which sounds a lot like a neuropsychologist, but the difference is a neuropsychiatrist is a medical doctor who specializes in prescribing medications that support thinking abilities as well as mood and behavioral difficulties. Now, again, some neuropsychiatrists start seeing a person who's had NORSE or FIRES while they're still in the hospital. Oftentimes they might wait and not see patients or prescribe medications until a person's had a chance to recover more fully and experience some benefits from rehabilitation. And generally, these visits are completed as an outpatient follow-up. Now, the last thing that I'm going to talk about is family and caregiver supports. Oftentimes patients and families are hugely impacted by NORSE, and I consider the patient's needs as well as the family's needs kind of together. And most individuals, as well as their families, would benefit from some form of counseling or even just psychoeducation with a provider like a psychologist or a neuropsychologist familiar with the condition to address some of the emotional emotional challenges that happen when such a significant illness happens and occurs, as well as problem-solving support. There are just so many decision points that having to make so many decisions, being so unfamiliar, can be very overwhelming, and it can be exhausting to have to make so many decisions for such a length of time. If a patient or a family would like to seek psychotherapy, one good form of psychotherapy is something called acceptance and commitment therapy that teaches healthy adaptation. There's other health psychology interventions that are very effective. And I would just like to note that sometimes family therapy is indicated because family structures can radically change because of a patient having NORSE or FIRES, especially in the adult populations. Individuals who just started to have children and have young ones of their own might suddenly be dependent on their own parents and not be able to care for their own families or children anymore. And it can completely upend family structures, and that might need some assistance. The last aspect is encouraging family and caregivers to make sure that they get their own support, divide responsibilities, utilize all available resources, and making long-term plans, planning ahead for the event of relapse or disability, and having a sort of a family agreement about what steps the family is going to take in the event of any future decline or care needs, and how patients and families are going to manage that together. So the take-home point of this is, remember to try and utilize all the available resources that you have at your disposal when leaving the hospital, and keeping in mind that you might need to get creative about how you're seeking these resources. Thank you.
Thank you so much, Dr. Sieg. It was really great to hear you kind of tie that all together, although I think it sounds like it may be a lot also for families to know. And when we come back, we were going to jump into some breakout groups to further discuss these topics in a little bit more detail. And so if you guys wanted to take 5 to 10 minutes, if anyone wants to take a break, they can just, instead of exiting the Zoom meeting, it's probably best just to turn off your video if you're going to take a break, and then hop back on before 9, I should say 11 o'clock. I'm in a different time zone, so I was getting confused there for a second, but before 11 o'clock, and then we'll start the breakout sessions.